Welcome back to the Rad Onc Smart Review Head and Neck Cancer series. Today we are really shifting gears. We're stepping out of the world of squamous cell carcinoma with its predictable lymphatic drainage, its HPV status.
Right, a world that has rules we've all come to know.
Exactly. And we are entering a much more complex, biologically diverse landscape.
That's right. This is episode 34, Salivary Gland One, Histology-Driven Biology and the Surgical Paradigm. And, I'm glad you said shifting gears because for a lot of residents, this is the topic where the wheels can really fall off.
It really is. It feels like the wild west of head and neck oncology. If you've spent the last month just cramming the rules for oropharynx or larynx cancer, you almost have to hit a factory reset button in your brain.
You absolutely do. Because in that mucosal world, T-stage and N-stage are king. That's what drives everything. But here, in the salivary world,
It's all about the histology.
it is all about the histology. The specific cell type you see under the microscope dictates everything, whether you cut, whether you radiate, and frankly, whether you can even look a patient in the eye and talk about a cure.
And the stakes are just incredibly high. We aren't just talking about, survival statistics here.
Not at all.
We're talking about the facial nerve, the very essence of how a person expresses joy or sadness or any emotion. We're talking about tumors that can kind of hide for decades and then just resurface.
So our mission today is to build a new mental model. We're going to establish what we're calling the salivary paradigm. We'll break down the anatomy that traps so many people. We'll categorize that just confusingly long list of histologies into 6 actionable buckets. And we'll walk through, the blood oath of parotid surgery.
And we're going to anchor all of this with a case that is an absolute classic for the oral boards. I mean, if you are sitting in that hot seat and you see a parotid mass with facial weakness, you have to know exactly what to say without a second of hesitation.
Let's get into it.
Okay, let's set the scene with this case, because this isn't just some textbook hypothetical. This is the patient sitting in your clinic, 8 a.m. on a Monday. You got a 62-year-old man.
Right. And his story, on the surface, is deceptively simple. He comes in with a mass in his right cheek, right in the parotid tail. He says it's been there for maybe 8 months, just slowly getting bigger. It doesn't hurt.
Yeah.
He hasn't been ignoring some massive ulcerating lesion. It's just a lump.
And that slowly enlarging history can be so misleading. It just screams benign to the uninitiated, doesn't it?
It does. It lulls you into this false sense of security. But then he drops the bomb. He tells you that over the last 6 weeks, his smile looks a little crooked. And when he washes his face, he can't quite squeeze his right eye shut.
That changes the temperature in the room immediately.
Instantly. You look at his chart. No pain, no trismus, no skin changes, no history of smoking or heavy drinking that would make you think of a standard squamous cell cancer. You examine him, and sure enough, there's a firm 3-centimeter mass in the parotid tail. But way more importantly, you document a House-Brackman grade 3 facial nerve dysfunction.
Okay, so for everyone visualizing this, grade 3 isn't total paralysis, right? It's obvious, but there's still some function.
Correct. Grade 3 is a moderate dysfunction. You can clearly see a difference between the two signs, but it's not a complete loss of tone. But clinically, it tells you one thing for sure. That nerve is compromised.
So you order the imaging, CT and MR. I show this 3.2 centimeter mass. It's enhancing, and it's diving deep. It's extending into the deep lobe, and critically, it's encasing the main trunk of the facial nerve.
And the PET-CT just lights up like a Christmas tree SUV max of 12. But here's the one saving grace. No distant disease, no spots on the lungs. Yet.
So you do the FNA, the fine needle aspiration. And the pathologist calls you and says, this isn't good. It's a high-grade carcinoma. We favor salivary duct carcinoma.
And there it is. The surgeon turns to you, looks at you, and says, what do we do?
Before we unpack all the biology and the decisions here, I want to hear how you handle this in the pressure cooker of an exam. What is the 60-second board script for this specific patient?
Okay, if I'm in the exam, I sit up straight, take a breath, and I say, this is a 62-year-old man with a 3-centimeter right parotid mass and clinical facial nerve dysfunction, with FNA showing high-grade salivary duct carcinoma. My workup confirms no distant disease on PET-CT and no clinical lymphadenopathy, though I have a high suspicion for occult nodal involvement given the high-grade histology. By size, he is at least clinical T2. Preoperative facial weakness makes me concerned for facial nerve invasion, which would be T4A, and I will confirm intraoperatively and pathologically. Surgery is the primary treatment, likely total parotidectomy, with facial nerve sacrifice given preoperative dysfunction. plus ipsilateral selective neck dissection. I would recommend postoperative RT to the parotid bed and ipsilateral neck, given multiple high-risk features. High-grade histology, advanced T-stage disease, and likely positive margins or perineural invasion. The key late effect I would counsel on is permanent facial nerve dysfunction, though if nerve grafting is performed, partial recovery is possible over 12 to 18 months.
That is tight. I mean,
Yeah.
you hit the diagnosis, the staging nuance, the primary modality, the extent of surgery, the whole adjuvant plan, and the counseling.
That's the standard. But there is a lot of density packed into that 1 minute. To really understand why that's the answer, we have to back up and, look at the whole landscape of this disease.
Okay, let's start with the basics. What exactly are we dealing with here in terms of, epidemiology? Salivary gland cancer is pretty rare, isn't it?
It is very rare. It only represents about 5% of all head and neck malignancies. We're talking maybe 2,500 cases a year in the United States.
But what it lacks in volume, it more than makes up for in variety.
Oh, it's a mess of complexity. This isn't one disease. It's a family of over 20 different histologic subtypes. And unlike squamous cell carcinoma, where one size often kind of fits all, here, every single subtype has a completely different personality.
To understand where these tumors come from and how they behave, we really need a refresher on the geography. Let's do a quick flyover of the anatomy. We usually divide the world into major and minor glands.
Correct. The heavyweight champion is, of course, the parotid gland. It's the largest, sits right there in front of the ear, and it wraps around the mandibular ramus. About 80 to 85% of all salivary tumors happen right here. Stenson's duct drains it into the oral cavity right behind the upper second molar.
And the parotid has a very famous and very important tenon living inside it.
The facial nerve.
Yeah.
Cranial nerve 7. This is the single most important anatomic landmark in all of parotid surgery. The nerve actually divides the parotid gland into a superficial lobe and a deep lobe. But it's important to remember, there isn't a membrane separating them. It's the plane of the nerve itself that creates that division.
So when we hear a surgeon talk about a superficial parotidectomy, they are literally talking about peeling the gland off the top of the nerve.
Exactly. It's incredibly high-stakes dissection. Then, if you move down below the jaw into the submandibular triangle, you have the submandibular gland. It's smaller, and it drains into the floor of the mouth via Wharton's duct.
And why is the submandibular gland so important for us as radiation oncologists?
Because the submandibular gland is the most important producer of mucinous saliva. That's the thick, lubricating kind. If you fried this gland with radiation, the patient gets terrible dry mouth or xerostomia. So that becomes very, very relevant when we talk about radiation planning later on.
Then we have the tiny sublingual gland, which is right under the tongue, draining via Bartholin's duct. And finally, you have literally thousands of minor salivary glands scattered all over the lining of the mouth and the throat.
Right, and the hard palate, the roof of your mouth, that's the most common spot to find those minor gland tumors.
Now, there's a classic rule of thumb for figuring out how worried you should be about a lump in any of these areas. It's called the rule of 80s.
This is a board anchor. If you remember nothing else about the epidemiology, you have to remember this. 1, 80% of salivary tumors arise in the parotid. 2, 80% of those parotid tumors are benign. And 3, 80% of those benign parotid tumors are pleomorphic adenomas.
Okay, that makes it really easy to remember the distribution. So statistically, a lump in the parotid is usually good news. It's likely benign.
Usually. But there is a catch. There's a flip side to this coin. We call it the inverse relationship. As the gland gets smaller, the news gets worse.
Yeah, what?
Meaning that while only about 20% of parotid tumors are malignant, if you find a mass in the submandibular gland, that risk of malignancy jumps to 50%.
50? Wow.
And if it's in the sublingual gland, we're talking 70 to 90% are malignant.
So a lump under the tongue is basically guilty until proven innocent.
Absolutely. And for those minor glands in the palate, 50 to 75% are cancer. So big gland equals lower risk. Small gland equals high alert.
Okay, we've got the anatomy down. Now let's tackle the monster. Histology.
Yeah.
You mentioned there are 20 plus types. We can't possibly memorize 20 different types today.
And you shouldn't even try. For the purpose of clinical practice and for the boards, I want you to group them into 6 behavioral buckets. This simplifies that whole list of 20 plus subtypes into groups that are actually actionable.
Okay, sounds good. Let's start with bucket 1.
Bucket 1 is the fascinating and frankly terrifying one. Adenoid cystic carcinoma, or ACC. This is really the poster child of salivary malignancy.
And why is it so unique?
It's unique for two main reasons. First, it is essentially a neurotropic missile. It loves nerves. It has the highest rate of perineural invasion, or PNI, of any of the subtypes. It will track along a nerve, completely asymptomatic, for centimeters away from the main tumor bulk.
That has to be a complete nightmare for surgeons who are trying to get clear margins.
It is. And the second reason is what I like to call the long con. ACC grows incredibly slowly. It rarely goes to the lymph nodes. We're talking only about 5 to 8% of the time, but it loves to travel to the lungs. Distant metastases happen in 30 to 50% of patients.
But the timing is the really tricky part, right? It's not immediate.
Right. It doesn't necessarily happen in year 1 or 2. A patient can be totally disease-free for 10 years and then show up in your clinic with bilateral lung nodules. You can never, ever truly discharge an ACC patient. They need lifelong surveillance.
That long concept is so important for patient counseling. You can't just give them a high five at the 5-year mark and say, hey, you're cured.
Never. Lifelong lung surveillance is absolutely mandatory.
Okay, that's bucket 1. What's in bucket 2?
Bucket 2 is mucoepidermoid carcinoma, or MEC. This is actually the most common malignancy you'll find in the parotid gland.
And what drives the bus here? What's the key feature?
Grade. Grade drives everything. A low-grade MEC behaves almost like a benign tumor. It's small, it's slow-growing, and it's curable with surgery alone. But a high-grade MEC behaves just like a nasty squamous cell cancer. It metastasizes early to the lymph nodes, and it has a poor prognosis. You have to know the grade before you can counsel the patient.
Bucket 3 sounds like the villain from our case today.
Yes. Bucket 3 is salivary duct carcinoma, or SDC. This is the bad actor. It is high grade by definition. There's no such thing as low-grade SDC, and it's much more common in older men, about a 4-to-1 ratio.
And physiologically, it has this strange doppelganger.
It does. Under the microscope, and biologically, it looks incredibly similar to high-grade invasive ductal carcinoma of the breast.
Breast cancer. Now, that's not just a piece of trivia, is it? It has real therapeutic implications.
Absolutely. Why does this matter? Because just like breast cancer, salivary duct carcinoma frequently expresses androgen receptor, or AR, and HER2.
So we can use drugs that we use in breast cancer, like Herceptin or hormone blockers.
Exactly. You should always order molecular testing for AR and HER2 in SDC. It gives you actionable targets down the road if the surgery and radiation fail.
Okay, bucket 4.
Bucket 4 is a actinic cell carcinoma. This one is the deceiver. It's generally considered low grade, it grows slowly, and the 5-year overall survival is excellent, around 90%.
There's always a but.
But it is another one of these long con tumors. If you look at the 20-year data, that survival drops all the way down to 55%. It can recur very, very late, or it can even transform into a high-grade version. You never turn your back on a actinic cell.
And bucket 5 involves the transformation we kind of touched on earlier.
Right. Bucket 5 is carcinoma x pleomorphic adenoma. This is what happens when a benign pleomorphic adenoma, which is the most common benign tumor, is just left alone for too long. It undergoes a malignant transformation. It represents about 4% of all salivary tumors, but 12% of the malignancies. And these are aggressive. You treat them based on the pathologic features of the cancerous part.
And finally, bucket 6, the catch-all.
Bucket 6 is what I call the treat by risk features group. This includes things like adenocarcinoma, NOS, any high-grade transformation of a low-grade histology, and squamous cell carcinoma of the parotid.
And there is a specific pearl for squamous cell in the parotid, isn't there? A big trap.
It is a huge trap. If you find squamous cell carcinoma in the parotid gland, your first thought should not be, oh, this is a primary parotid cancer. Your first thought should be, this is a metastasis from the skin.
Ah.
You need to immediately check the patient's scalp, their ears, their face. It is almost always a skin cancer that has traveled down the lymphatics and set up shop in the parotid.
That covers the... Now let's talk about the how. How do we properly work these patients up?
So the standard workup starts, as always, with a good history. You want to focus on that painless mass, the duration of its growth, and any symptoms that suggest nerve involvement. So facial weakness, numbness, or pain. Risk factors are, they're pretty poorly defined compared to mucosal head and neck cancers, though there is evidence for prior radiation exposure. Think about survivors of Hiroshima and Nagasaki. And smoking is a specific risk factor for a benign tumor called Warthin's tumor.
And the physical exam?
The physical should include a complete cranial nerve assessment, especially facial nerve function, using that House-Brackman grading system. Plus, you're looking for skin fixation, trismus, and any palpable cervical lymphadenopathy.
Imaging is next. What's our typical sequence?
Ultrasound is great for the initial workup of a parotid mass. A CT of the head and neck with contrast is your standard for surgical planning. MRI is really crucial if you have any concern for perineural invasion, skull base involvement, or deep lobe extension. And PECT is typically reserved for stage 3 to 4 disease.
And for tissue.
Fine needle aspiration, FNA, is first line. A core biopsy might be needed if that FNA comes back non-diagnostic.
Okay, staging. This is where people get tripped up on the boards all the time. Let's really anchor the T stages.
Staging for the major salivary glands is primarily size-based, but with some very important modifiers. T1 is 2 centimeters or less, with no extraparenchymal extension.
Yeah.
T2 is greater than 2 centimeters, but 4 centimeters or less, again, no extraparenchymal extension. P3 is greater than 4 centimeters, OR, and this is the big one, it has extraparenchymal extension.
Okay, stop there for a second. Because that extraparenchymal extension, meaning it's growing out of the gland itself, that's a really nuanced point.
This is a critical staging nuance for the boards. Per the AJCC 8th edition, that extraparenchymal extension has to be clinical or macroscopic.
Meaning you have to be able to see it with your naked eye or feel it on exam.
Yes. Gross invasion that's visible on the imaging or palpable on the physical exam. If the pathologist looks under a microscope and sees, a few cells just trickling out into the fat, but the surgeon didn't see it and the scan didn't show it,
That does not count.
it does not count. Do not upstage to T3 based on incidental microscopic extension alone.
That is a huge point. Microscopic doesn't count for upstaging. Okay, so what about T4?
T4A is when it invades critical local structures. The skin, the mandible, the ear canal, or the facial nerve. T4B is when it gets really bad invasion of the skull base or it's encasing the carotid artery.
I use a mnemonic for T4A.
Oh, yeah.
The staging hook for boards here is FEMS, facial nerve, ear canal, mandible, skin. If it hits any of those, it's T4A.
FEMS. I like that. That's a good one. It sticks. And our patient with his facial nerve dysfunction.
Clinically, he's T4A.
Correct. He's T2 by size because he's only 3 centimeters, but that nerve involvement trumps the size every time.
Now we have to make a treatment decision. And in salivary cancer, there is a golden rule.
The golden rule is surgery first. Whenever it is technically feasible, surgery is the absolute backbone of cure. This is not organ preservation territory like a tonsil cancer. Resection is the priority.
But cutting these tumors out isn't simple. You are operating in a minefield of nerves. Let's talk about the surgical approach.
The standard is a parotidectomy. You can do a superficial parotidectomy. That's resection of the tumor superficial to cranial nerve 7, which is appropriate for small, low-grade tumors. Or you could do a total parotidectomy resection of the entire parotid gland with nerve sparing, which is what you do when there's deep lobe involvement.
But the whole decision tree for the surgeon really hinges on the facial nerve. Walk us through the NCCN logic here. The surgeon is in the OR. They see the nerve. What do?
Okay, scenario A. The nerve is functioning perfectly fine preoperatively, and in the OR, it can be separated from the tumor. In this case, you preserve the nerve, even if it's close. You dissect it off.
Okay. And scenario B?
Scenario B. The nerve was already paralyzed before the operation, like our patient today. Or the surgeon gets in there and finds direct, undeniable tumor invasion of that nerve. In that case, sacrifice becomes necessary.
That is a heavy moment in the operating room. You are intentionally paralyzing the patient's face to save their life.
It is. And you have to reconstruct it. Usually they'll take a nerve graft, often from the greater auricular nerve in the neck or the sural nerve from the leg, and they'll bridge that gap.
And does that actually work? Do people get their function back?
It works.
Yep.
Partially. You have to counsel patients that partial recovery of facial function is possible, but it takes 12 to 18 months, and complete recovery is very uncommon.
There's one other absolute rule in this surgery. I call it the do not drop rule.
Avoid spillage. Tumor spillage, particularly with pleomorphic adenoma, dramatically increases the risk of local recurrence. If you rupture that capsule and spill tumor cells all over the wound, you've created a disaster. That's why you avoid enucleation. You need a cuff of healthy tissue. You're aiming for a margin of 1 to 2 millimeters minimum.
Okay, surgery is done. The tumor is out. Now we look at step 2, postoperative RT. Do we radiate everyone?
No, definitely not. I think of it as a risk ladder. If you have a low-grade tumor like an MEC or an acidic, and it was small, so T1 or T2, and the margins were widely negative, that is the low-risk rung of the ladder. Surgery alone is sufficient for that patient.
So what pushes you up the ladder to needing radiation?
A few things. First, just the histology itself. If it's adenoid cystic carcinoma,
Nerve tracker.
yep, a CC almost always gets postoperative RT, even if it was T1N0, just because of that incredibly high risk of microscopic nerve tracking.
So ACC equals radiation. Got it.
Correct. The second category is what we call the high-risk features, so intermediate or high grade, close or positive margins, T3 or T4 disease, node positive, PNI or LV I found on pathology. Any one of these features means the patient needs postoperative RT.
And our patient today.
He checks almost every single box.
Yeah.
High-grade SDC, clinically T4A. He's almost guaranteed to have PNI. He absolutely needs radiation.
What about his neck nodes? His scan was negative. Do we treat the lymph nodes anyway?
This is a really key decision point. If the nodes are clinically positive, obviously you treat them. But if they're clinically negative, we have to look at the probability of occult or hidden disease. If the tumor is node negative, but it's a high-grade histology or a T3 to T4 parotid primary, then you should strongly consider elective neck irradiation.
And which levels are we talking about?
We rely on the Warshawski meta-analysis from 2020. It showed that for parotid malignancies, the dominant risk is at level 2. Level 2 had over a 16.5% occult rate. Levels 1 and 3 were much, much lower. So at a minimum, you're treating ipsilateral levels 2 through 3 and maybe plus or minus level 4.
But for a submandibular tumor, you'd have to include level 1B, right? The geography matters.
Exactly. Geography is key. Level 1B is low yield for a parotid primary unless there's specific extension, but it is mandatory for submandibular primaries.
Are there any cases where we can skip the elective neck radiation even if we're radiating the primary tumor bed?
Yes. For node-negative adenoid cystic or acinic cell, you can often omit elective neck treatment for those, based on data from Chen in 2007 that showed no nodal failures in that population. A CC goes to the lungs, not the nodes.
Okay, now here is the big controversy. In squamous cell head and neck cancer, if we have positive margins or other high-risk features, we add chemotherapy. We give cisplatin. Do we do that for salivary gland cancer?
This is the single biggest board trap in the entire subject, and the answer is generally no.
Residents instinctively want to say chemoradiation. Why is that wrong here?
Because we just don't have the level 1 evidence that it works. In fact, an analysis of the National Cancer Database by a mini back in 2016 showed equivalent or potentially even worse survival with the addition of chemotherapy to post-op radiation.
That's really counterintuitive for a lot of residents who are used to the squamous cell world.
It is, but the data just isn't there yet. The ASCO guidelines are very clear on this. Concurrent chemotherapy may not be routinely offered outside of a clinical trial.
Is there a trial looking at this?
Yes, RTOG 1008. It's comparing post-op radiation alone versus post-op radiation plus weekly cisplatin. But until that trial reads out, you do not reflexively add chemo.
So if you say chemo-RT on your oral boards without qualifying it, without saying on a clinical trial, you will fail that section.
You absolutely will. You have to show that you know the controversy exists.
Let's talk about the key evidence that really built this entire framework. Where does this come from?
We really rely on a few major pillars. First, there's the Armstrong MSKCC paper from all the way back in 1990. This was an early matched pair analysis, and it was the first to really establish the benefit of post-op radiation for advanced disease. It showed better overall survival and local control when it was given for stage 3 to 4 or node-positive tumors.
And then the Terhard study.
That's the Terhard Dutch Registry data from 2005. It was a bigger cohort, and it confirmed that post-op radiation improves local control for T3 to T4 disease, for close or positive margins, and for perineural invasion.
And then most recently, we have the ASCO guidelines by Geiger in 2021.
Right. And this is the contemporary summary. It basically reinforces everything we've just said. Offer RT for all the high-risk features and for ACC, but hold off on the chemo outside of a trial.
Okay, let's apply all of this. Let's bring it back to our case. We have the 62-year-old man, 3-centimeter mass, facial nerve dysfunction, high-grade salivary duct carcinoma. What's the final plan?
My recommendation would be this. This patient requires a total parotidectomy with facial nerve sacrifice, giving his preoperative dysfunction, plus an ipsilateral selective neck dissection of levels 2 through 3, given the high-grade histology. Nerve grafting should absolutely be discussed with the surgical team.
And the adjuvant plan after that.
Post-operatively, I will recommend adjuvant RT to the parotid bed and the ipsilateral neck. There are multiple high-risk features present.
Yeah.
The high-grade histology, the advanced T stage, and the very high likelihood of perineural invasion.
And how are you dosing this?
For dosing, I would deliver 60 to 66 gray in 30 to 33 fractions to the high-risk volume, that's the parotid bed, the entire nerve pathway, including the stylomastoid foramen, and any involved nodal levels, with 54 gray going to the elective nodal volumes.
And what about molecular testing?
Given that it's a salivary duct histology, I would absolutely recommend molecular testing for androgen receptor and HER2 status.
Yeah.
This doesn't change our upfront management, but it provides really important, actionable targets if the patient ever recurs down the line.
I want to hear how you would actually explain this to the patient. I mean, the nerve sacrifice is such a huge deal.
Right, so here's my counseling script. The surgery will remove the tumor and the facial nerve, which, as you know, is already not functioning well. Our surgeon will try to graft a new nerve, but the recovery of facial movement takes a long time, 12 to 18 months, and it's usually partial, not complete. You will need to protect your right eye very carefully until you can close it fully again. After surgery, I'm going to recommend radiation to reduce the chance of this cancer coming back in your cheek and your neck. The main side effects are dry mouth, fatigue, and skin changes during treatment. Long-term, the most important issue is a permanent loss of saliva on that side, which we can help you manage. And finally, this type of cancer can sometimes come back in the lungs years later, so we will follow you very closely with imaging, including chest scans, for many, many years.
That covers the toxicity nicely. Let's expand on that just a little bit. What are the things that keep these patients up at night?
Well, the late effect story really centers on two things.
Yeah.
That facial nerve dysfunction and xerostomia. Preoperative facial nerve paresis is a really bad prognostic sign. It's both a marker of aggressive biology and, for the patient, a functional catastrophe.
So we have to counsel them on eye protection.
Absolutely. Artificial tears, taping the eye at night, maybe even a tarsorrhaphy if it's severe, not to mention the changes to their speech and facial expression.
And the xerostomia, the dry mouth.
This is what I call the parotid sparing paradox. Usually in head and neck cancer, we try to spare the parotid glands to save saliva. But here, we are intentionally obliterating the parotid glands on the sick side. It is the target. So you have lost 50% of your saliva production instantly.
So the whole game changes.
It does. Your constraint focus shifts entirely to the contralateral parotid gland. You have to fight like hell to keep the mean dose to that healthy parotid as low as possible, classically around 25 to 26 gray. You try to spare the submandibular glands if you can, keeping them under 39 gray.
And there's one weird one, Frey's syndrome.
Yes. Gustatory sweating. It's when the nerves regrow incorrectly. Instead of telling the salivary gland to make spit when you eat, the parasympathetic fibers accidentally connect to the sweat glands in the skin. So the patient takes a bite of an apple and their cheek starts sweating profusely.
It sounds bizarre, but it's very real.
Very real and very bothersome for patients.
We have covered a lot of ground. Let's try to consolidate this with a board blitz. I'm going to throw a scenario at you, and you tell me the next step.
Let's do it.
Question 1. A 58-year-old woman undergoes a superficial parotidectomy for a 2-centimeter mass. Final pathology shows low-grade mucoepidermoid carcinoma. Margins are negative at 8 millimeters, no perineural invasion, and no lymphovascular invasion. What is the most appropriate next step? A. Postoperative RT to 60 gray. B. Postoperative chemoradiation. C. Completion total parotidectomy. Or D. Observation with surveillance imaging.
The best answer is D. The reasoning here is this is the low-risk winner. It's a low-grade MEC, it's T1, it has widely negative margins, and no other adverse features. Per the principle, port for all but low-grade T1 to T2 with negative margins. This patient can be safely observed. Option A is incorrect because PERT isn't indicated. Option B is doubly incorrect. And C is incorrect because the tumor was already completely excised.
Perfect. Question 2. A 65-year-old man has a 3.5 centimeter parotid adenoid cystic carcinoma, cribriform pattern, that's been resected with negative margins. Pathology shows incidental perineural invasion around some small unnamed nerves. His facial nerve function is totally intact. No lymphadenopathy. What's your recommendation? A. Observation. B. Port to the parotid bed only. C. Port to the parotid bed plus the elective ipsilateral neck. Or D. Port to the parotid bed plus the bilateral neck.
The best answer is B. The reasoning is that adenoid cystic carcinoma should receive port in nearly all cases because of that high PNI rate. The incidental PNI on pathology just confirms that need. However, ACC has very low nodal metastasis rates, 5 to 8%, and per that Chen data from 2007, no nodal failures were seen in ACC when the elective neck was omitted. So the primary bed should absolutely be treated, but the elective neck can be omitted for node-negative ACC.
Excellent. Last one. Question 3. A 7-year-old man undergoes a total parotectomy with facial nerve sacrifice and an ipsilateral neck dissection for salivary duct carcinoma. Final pathology shows T3. It's 4 centimeters with gross extraglandular extension, 2 positive level 2 lymph nodes with extranodal extension, and a close margin at 1 millimeter. What is the most appropriate adjuvant therapy? A. Port 60 gray to the parotid bed, 54 gray to the neck. B. Port 66 gray to high-risk areas, 60 gray to the parotid bed, and 54 gray to the elective neck. C. Port plus concurrent cisplatin. Or D. Port plus concurrent weekly cisplatin.
The best answer is B. This patient has multiple high-risk features. A high-grade histology, T3 disease, positive nodes with ENE, and a close margin. He needs comprehensive post-op radiation with dose escalation. 66 gray should go to the areas of ENE and that close margin. Options C and D, which add concurrent chemotherapy, are incorrect because that is not standard of care outside of a clinical trial per the ASCO guidelines.
Fantastic. Let's distill this all down to the clinical pearls. What are the key takeaways for the listener to carry in their pocket?
Pearl 1. Remember the rule of 80s. 80% of salivary tumors are in the parotid, 80% of those are benign. But remember that inverse relationship. The smaller the gland, the more likely it is to be malignant.
Pearl 2.
Pearl 2. Adenoid cystic carcinoma is the long con. It has the highest PNI rate and is famous for late-distant metastases to the lung. Lifelong surveillance is absolutely mandatory.
Pearl 3.
Pearl 3. Surgery is primary. Respect the facial nerve, preserve it unless there is preoperative dysfunction or direct, undeniable invasion.
Pearl 4.
Pearl 4. Know your port triggers. Grade 3 histology, positive or close margins, T3 to T4 disease, positive nodes, PNI, LVI, or an adenoid cystic histology.
Pearl 5.
Pearl 5. No routine concurrent chemotherapy outside of a clinical trial. Don't fall into the squamous cell trap.
And Pearl 6.
Pearl 6. Extraparenchymal extension for T3 staging requires clinical or macroscopic evidence. Microscopic expansion alone does not count.
And finally, for the surgeons listening,
Do not spill the tumor.
simple as that. This has been a really detailed look into the complex world of salivary gland malignancies. We've established that the histology drives the behavior, surgery is primary, and post-op radiation follows for those with high-risk features.
And in episode 35, we are going to dive deep into the practical side of this.
Yep.
Adjuvant RT triggers and planning how to actually contour the parotid bed, what dose levels to use, when to cover the neck, and all the technical details that will make you confident at the planning workstation.
Complete practice oral boards at radonsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.